Welcome to Know and Go Friday Showcase, and welcome back to many of you, lots of familiar faces. My name is Holly Brenner. I'm the Vice President of Strategic Development and Marketing for our system, and I am very appreciative for you spending your time with us this morning. We will go ahead and get started with a reflection and a little housekeeping, and then we'll put Dr. Milani up front and center so you can ask him questions and he can share with us about the Hospitalist program. So this reflection is called the Dash, and I've been waiting for a good opportunity to use it. Terry St. Lawrence brought this to one of our team department meetings a month or so ago, and it's just one of those that kind of makes you think. So, the Dash. I read of a man who stood to speak at the funeral of a friend. He referred to the dates on the tombstone from the beginning to the end. He noted that first came the date of birth and spoke the following date with tears. But he said what mattered most of all was the dash between those years. For that dash represents all the time that they spent alive on earth, and now only those who love them know what that little line is worth. For it matters not how much we own, the cars, the house, the cash. What matters is how we live and love, and how we spend our dash. So think about this long and hard. Are there things you'd like to change? For you never know how much time is left that can still be rearranged. If we could just slow down enough to consider what's true and real, and always try to understand the way that other people feel, and be less quick to anger and show appreciation more, and love the people in our lives like we've never loved before. If we treat each other with respect and more often wear a smile, remembering that this special dash might only last a little while. So when your eulogy is being read, with your life's actions to rehash, would you be proud of the things they say about how you spent your dash? A little deep maybe, but thought-provoking, I thought. Dr. Milani is here, Dr. Alan Milani. He's the director of the Hospitalist group here on this campus. He graduated his medical school from Frederick and the Medical College of Wisconsin, great partners of ours, as you know. Did his residency and training in the University of Southern California, and was chief of staff at St. Agnes Hospital here from 2012 to 2014, and is currently the president-elect for our Fond du Lac County Medical Society. So we are blessed to have Dr. Milani as part of our ministry, and we're very, very fortunate, I know what his schedule looks like, to have him here for us today, this morning. Please enjoy the program this morning, and then also go back and tell your peers, tell your friends that he'll be back again for the encore at noon. So without further ado, Dr. Milani.
Good morning, everyone. Thanks for the introduction there. Pleasure to be here and have an opportunity to talk about the Hospitalist program and Hospice group. Feel free at any point to interrupt and ask questions. Kind of keep it an informal discussion, so if you have any thoughts or questions, feel free to let me know. What we'll do is start off by talking about hospitalists in general, give everybody an idea what hospitalists do. Then we'll talk about some of the advantages, benefits of having hospitalists. We'll talk about quality outcomes data, which I think is probably very important to everybody in here as healthcare workers. And finally wrap it up with talk of our hospitalists at St. Agnes and Agnesian HealthCare. With that, how many of you, I'd like to just start off, I see a lot of familiar faces, but know about hospitalists and heard about hospitalists? Okay. Last time I asked that question, it was about 3 hands went up. Nice. Making progress. So let's talk about hospitalist. What is a hospitalist? Hospitalist is a physician who specializes in providing medical care in the hospital. Just simply put, you work in the hospital, you don't have outpatient practice. Essentially, your office is the hospital. It'll kind of be a recurring theme throughout the whole talk. Generally, they're internal medicine trained. That's about 80% of hospitalists. About 10% or so are family medicine, and then another 10% from other specialties, but about 80% internal medicine trained. The first time hospice was used was in the 1996, and around the mid-1990s is when hospice started coming around. Certain groups, we'll say, had a big group would have a few of their providers just handle the hospital work, and subsequently that's kind of what got the whole field started, was termed hospitalist. In the mid-1990s, those, as you can see, a few hundred to now it's expanded to about 20 to 30,000 hospitalists. So in about 20 years or so. Very rapidly growing field. I think of all the physician group specialties, it may be the most rapid growth in the past, we'll say 10 to 20 years. The number of hospitals that have hospitalists, probably about 60 to 70%. and I think it's going to continue to grow to essentially all hospitals have hospitalists. The hospitalist model is probably the best adapted model, and it says as best practice for high quality coordinated care and cost-effective management of hospitalized patients. I think this kind of last statement is going to be a recurrent theme through our talk of just best practice for high quality care, coordinated care, and cost-effective management of patients. This is essentially straight out of this definition here, was essentially straight out of the Society of Hospitalist Medicine definition of hospitalist. Let's look at kind of compare and contrast the hospitalist versus the prior, well, it's still current model with some groups in some places. We'll say traditional model, you have the primary care physician who sees the patient on an outpatient basis, and when the patient's hospitalized, will follow them in the hospital, take care of them, and then subsequently continues to follow them as an outpatient. I kind of, in the past, have gotten asked about this, we'll say the traditional model. There's one big benefit to it, is that the primary care provider knows the patient. Maybe he's been following the patient for a number of years. So as a patient, you hear sometimes occasionally that, well, where's the doctor that's taken care of me in the past? They've known me. They know all my medical conditions. They've admitted me in the past. So there's some benefit to this model. But I think as we go on, you'll see that the hospitalist model, essentially, the benefits outweigh this somewhat benefit from primary care providers. For the hospitalist model, you have the primary care physician manage the patient in the office, takes care of their outpatient medical conditions, and then once admitted, assumes care of the patient. The hospitalist, once admitted, assumes care of the patient. Then subsequently, when you're discharged, the patient goes and follows up with their primary care provider. Some of the advantages, this is going to be kind of a recurrent major advantage of hospitals is accessibility. Being available and on-site frequently. Again, as the hospitals being your office, they're on-site, available to see patients, families readily, manage tests in a timely fashion, get test results in a timely fashion, work with consultants, and then a big kind of agenda for hospitalists is discharge. Perform discharge in a prompt, timely manner and appropriately. So this is one very major, big issue for hospitalists is accessibility. Hospital functions and committees. Hospitalists generally know the functions of the whole hospital. From the emergency department, you see the patient down in the emergency department, interact with you can also see the patients on the floor. I don't want to necessarily say all in the emergency department. But you get to know the emergency department personnel, from the physicians, the staff down there to the floor. You interact with the floor personnel, with the ancillary services, we'll say the nursing, you get to know them well, the care management, the therapists, physical therapy, occupational therapy, the social workers, care navigators. So you kind of know the whole function, and then throughout the hospital, and at discharge, again, you involve a lot of the personnel and get to know the functions of the hospital. So this tends to be one of the assets of hospitals, is being involved in hospital functions and committees. Myself, a couple of the committees that I'm on is the Pharmacy and Therapeutics Committee and the Performance Improvement Committee. Another one's Antibiotic Stewardship, some of the committees that I happen to attend, and the Antibiotic Stewardship Committee, the chair of that committee. Utilization of resources, this is probably a major one for, we'll say, hospital management. Across the board, 20 to 30% is shown that hospitalists utilize resources more efficiently. Multiple studies have shown this. And the key point with that is that the quality does not drop at all. So you get a benefit of 20 to 30% without any drop in quality of care. As everybody knows, nowadays, medicine, the cost of medicine is very high, skyrocketing. It's a big issue throughout on the news, as you can see with Medicare. So this is, again, one of the reasons why I think hospitals are going to continue to take off, is helping us with cost containment. So multiple studies showing that it's about 20 to 30% benefit for resource utilization. Another big push that for hospitalists that I'll say primary care has quite a few primary care have given up their hospital practices, outpatient hospital practices, is the complexity of the patients in hospitalized care. With the advancing technologies, advancing medications, newer antibiotics, all kinds of other newer diabetic agents, other agents, and also the higher acuity of hospitalized patients nowadays. There's, as everybody knows, somewhat of a pressure to try to treat everybody as an outpatient as much as possible, the cost containment process. But with these components, that's why hospitals have really taken off. It's become a little bit complex for the primary care providers to have a very busy practice. Sometimes we'll say seeing 10, 15, 20 plus patients in the clinic to manage the complexity of the outpatient and then come and see patients in the hospital. And sometimes you'd have to come maybe before your office hours, during lunch, or after your office hours. So it was obviously made it difficult to manage the patients. And that's why hospitalists have really a push for primary care to give the hospitalized work to the hospitalist. And then quality measures and outcomes, this has become a very big issue. We'll touch upon a little bit more and affects all of us in here, is the outcomes data is becoming more and more important. 10, 20 years ago, there's really not much data. Now it seems like almost on a yearly basis, there's more data collected on hospitals and hospital care. And we'll look at that a little bit more in depth here. Any patient benefits, let's touch upon that. Shorter waiting times for beds. Hospitalists help alleviate the waiting time in the emergency department and help facilitate the patients being admitted. Certain places, this is a very big issue where the emergency department is constantly full and they basically have to house the patients in the emergency department. We're not as bad here, but it helps with the wait times, essentially, with the hospitalist. And this is, for the emergency department, this is one of their quality measures, is how fast the patient is admitted from the point of decision made to be admit the patient to reaching a hospital bed. So this is one of the big advantages of hospitals, is help expediting that process. Better communication, hospitalists work only in the hospital, so when needed, they can address issues faster, they can respond to patients quicker if needed, and obviously it affords more time to spend with the patients and family members. And all this in general leads to personalized, family-centered type care. Shorter hospitalization stay. Again, this is one of the we'll say, evidence-based support of hospitalists is they tend to decrease the hospitalization stay by probably 30%-ish. As a hospital provider, you help coordinate care with the hospital staff, with various ancillary services. You expedite getting tests done, getting the results of tests, and work very closely with the consultants to ensure that everything's done in a timely manner and the patient is we'll say dispositioned appropriately and in a timely manner. Quicker discharges, I think that kind of goes along with what we talked about. Hospitals, again, you're readily available to be able to give discharge as needed, as opposed to if it's a surgeon or primary care provider who may be tied up doing other, whether it's a surgeon's surgery or a primary care provider seeing outpatients. Quality of care. I think overall, you can kind of see with the accessibility, the reduced, the accessibility, the timeliness of tests, seeing patients multiple times in a day if needed, that overall in general, the quality care seems to be just as good, if not better, depending on how you look at it. We interact closely with the specialists and departments in the hospital and ancillary services, adjusting treatments throughout the day and responding fairly quickly to conditions as you need to. Now to touch upon the quality measures. This is quality outcomes data. I think as healthcare workers, as potential patients, as having family members as patients, is maybe the most important part of the know and go, if you will. That looking at the the various quality measures here. Before I get into that, how many people here have gone to a website or the internet and maybe compared hospitals? A show of hands. Okay, and how many of you have maybe gone to any website or internet and compared physicians? Okay. Well, I think this is not something that's very prominent. I don't think it's very prominent now, but I think it's going to be something that's going to gain a lot of, let's say, headway. If we could go to that, and before we go to that website, these are the basically a couple reasons to look at these quality outcomes data. One, it shows what hospitalists the conditions the hospitalists have to deal with, and kind of the standard we're held to. And also from your standpoint, again, this affects everybody, whether as a patient, as working in the healthcare field, or with family members as potential patients. So you just go to there's a couple of sites that do this. This is the main website. We'll say Medicare.gov, Hospital Compare. You can put in a zip code and look at the hospital. You can compare various hospitals, or look at just individual hospitals. To show you some of the data that's looked at here is the survey of patient experience, timely and if you can scroll, so that's okay. Timely and effective care, readmission and complications, and then some of the other ones we won't necessarily talk about: use of medical imaging, Medicare payments, number of Medicare patients. We won't necessarily touch on those. For example, the survey of patient experiences, patients hospitalized, they'll get a survey and ask questions such as how the communication of the nursing staff, communication of the physicians, where you explained your medications at discharge, ask things like the cleanliness of the hospital, whether the hospital, the noise environment of the hospital, survey that patients get. Something we've been working very diligently at. Could we click on the timely and effective care, please? We can scroll down. Thank you. A little bit more. That's fine. So you can see all the conditions that are looked at: heart attack care, heart failure care, pneumonia, surgical care, emergency department care, preventive care, child asthma we won't necessarily talk about, and then some of the newer measures as of this year, stroke care, blood clot prevention and treatment, and then pregnancy and delivery care. To just give you an idea of what these measures look at, I'll just give you a little bit brief rundown of each measure. For the heart attack care, it looks at things along the lines of if the patient's received aspirin appropriately in a timely fashion, whether they've received certain medications such as ACE or ARB inhibitors appropriately if indicated, beta blockers if indicated, if they've received blood thinning treatments if appropriate, if, again, appropriate, they've received interventions for heart attacks, and then subsequently discharged appropriately on cholesterol-lowering medications. So that's kind of one of those are the breakdown of the data looked at in heart attacks. For heart failure, some of the measures looked at is, did you evaluate the heart function and then subsequently give appropriate medications based on that evaluation. For the pneumonia measures, it looks at whether appropriate blood labs were drawn, specifically blood cultures, and whether appropriate antibiotics were given. For surgical care, we can click on one of these. How about surgical care? We'll click on. You can scroll down a little bit. Well, yeah. Surgical care looks at a number of measures, and this one seems to be expanding almost routinely. But let me step back and talk about Association of Hospitalists with surgical team. If a patient comes in with a surgical condition, they're likely admitted to the surgical team, and then the surgeons, whoever the surgeon is, maybe whatever specialty that is, can contact the hospitalist to help manage their hospital care. So if they have diabetes, hypertension, help with medication management, help with antibiotics. A good association of this that's shown outcome improvements is orthopedics. If you have, we'll say, elderly with lots of medical conditions, lots of medications, has been shown really good outcome improvement if you have the hospitalist come on board and help manage the medical conditions and let the orthopedic surgeon do their part, the surgery. So that's how the association works. At times the hospitalist will admit the patient, be the primary, we'll say, provider in the hospital for the surgical patient, and the surgical team will do their part, and subsequently the hospitalist will take care of their medical conditions. So that's how the interaction is with the surgical teams. Some of the, now stepping to some of the surgical measures is the receiving antibiotics appropriately before the surgery, discontinuing the antibiotic appropriately after the surgery, in cardiac surgery, monitoring the blood sugar closely, appropriate hair removal, urinary catheter removed within an appropriate amount of time, continuing certain medication called beta blocker appropriately, and one of the big measures that's growing is appropriate prevention of blood clots, giving the appropriate treatment for prevention of blood clots. We can close that one down, go to the next one. Emergency department, just essentially the only measure that from a hospital standpoint is the time that, as we talked about before, time and the patient is admitted from the decision being made in the emergency department to admitting the patient. If we can go to stroke care. Stroke care at St. Agnes Hospital, we're a primary stroke center. We get the transfers from surrounding hospitals, including Waupun, Ripon, and other hospitals that send their stroke patients to us. As the hospitalists, we're almost always the primary admitting providers for those patients. Then we call the neuro team as needed, as indicated. Quite a number of measures under the stroke title, so we can go over those. Some of the measures are appropriately giving blood thinning agents as indicated for the stroke, evaluating the stroke, the type of stroke, then giving the appropriate blood thinning medications, giving the appropriate blood clot prevention treatments, giving appropriate cholesterol lowering agents as indicated, giving education on stroke, and then assessing the patient for rehabilitation. And from my standpoint, I think in general, our stroke care is really outstanding throughout at this institution. We really tend to provide, I believe, excellent care in the stroke area. We can just close that one out. Then, as I was mentioning, some of the, there's this new one regarding blood clot prevention and treatment, and that's just giving the appropriate medications to prevent blood clots while in the hospital. And then if a patient is admitted with blood clots, giving the appropriate treatment. And I think we can go back to the top now. Just go. The data being collected, if we could go to this one, readmission and complications and deaths. This, another very big issue from hospital and hospitalist standpoint. Medicare is looking closely at 30-day readmission rates for the conditions we talked about, including heart attack, heart failure, pneumonia, hip and knee surgery, strokes, COPD, and just hospital-wide. And this is something as a hospitalist we're working diligently on to address any issues. And then also looking at the death rates or mortality for the same conditions, the heart attack, heart failure, pneumonia, COPD, and stroke. At this point, any questions regarding any of those outcomes data?
How do we stack up, Dr. Milani, to the rest of the world and hospitals in general?
I think we're the best.
Very good. Good answer.
Now, once you leave the room, I'll tell you the numbers. No, I think we stack up very well. We're doing, I would consider in readmission rates, we're very good. Mortality rates, very good. And in general, overall, very good, making good strides. Throughout the years, since the measures have come up, about 10, 15, 20 years ago, there was no measures. So since they've come, we've constantly made improvements. And I think comparing statewide, nationwide, we do really, I'd say, good to excellent, depending on the categories. So, other questions?
You mentioned earlier antibiotic stewardship. What kind of committee is that? What does that do?
Well, the Antibiotic Stewardship Committee is a committee that basically gets together and tries to decide on the appropriate use of antibiotics. There's usually in any condition like pneumonia, there's different antibiotics you can use, and we try to work through it, using evidence-based data and cost effectiveness, what's the appropriate antibiotic to use in that situation, such as pneumonia, such as cellulitis, that's basically skin infections, urinary tract infections, we'll say infections, severe infections, the appropriate antibiotics that we want to, as an organization, use primarily. It's a very big topic, and kind of the next, it didn't come up on here, I think it comes, I'm sorry, it is right here. Healthcare I was going to just touch upon it, is that healthcare-associated infections, very big topic now and growing, is hospital-acquired infections, as I'm sure some of you are aware or have heard of. The few infections really looked at and measured are central line infections, if a patient has a large IV and that becomes a source of an infection. Catheter-associated infection, if you have a urinary catheter and that becomes a source of an infection. And specifically looking at hospital-wide infections such as MRSA or C. diff. MRSA can affect different areas of the body. C. diff is mainly your bowel type infection. So those are being looked at. And then also just overall infections caused while hospitalized and hospital-acquired infections. This has become a very big topic. I'm sure some of you have heard of it. So that's why even that antibiotic stewardship is deciding which antibiotics we're going to use and hopefully address some of the infection conditions.
Dr. Milani, this is off the topic,
Sure.
but along the antibiotic line, there's a lot of publicity about the use of antibiotics, and it's created some resistance and all these things. Is that real?
Definitely it's real, but there's a lot of, I'll say, confounding factors. If, as an outpatient, if you go see your primary care provider, or as an inpatient, when we admit somebody, it's really difficult to sit there and watch and wait without treating. And that's probably the ideal way is limit antibiotic usage. I do believe that, yeah, there is resistance because of overuse. But the flip side is, in an individual case, we want to use the antibiotics. We don't want to kind of wait and see necessarily, because maybe the outcome is bad, and we don't want to be that one that's the outcome is bad. So there is definitely overutilization of antibiotics. Is it going to be limited? Probably not. I think, individually in that situation, as a provider, I think universally, you're going to err on the side of caution in using antibiotics versus not and waiting. So moving from there to the hospitalist functions, as we talked about, a hospitalist admits patients. They see patients, the ER physician calls a hospitalist, or ER provider, I should say, and discusses the patient. The patient is possibly seen in the emergency department, possibly seen on the hospital floor. During daily functions, the patient's seen and evaluated. Labs are reviewed, labs are ordered, studies are ordered and reviewed, orders are put in the computer, charting is done, and then lots of, and I really do want to emphasize, coordinating care with the nursing staff, with the care management, pharmacy, physical therapy, occupational therapy, pastoral care, care navigators. I'm sure I missed a couple in there, but it's a very coordinated effort. And then the EMR stands for electronic medical record. As hospitalists, we tend to be some of the forefront in using electronics. As everybody knows in here, maybe don't, that the last year we went to provider order entry, so all the orders are done with the computer system. And as hospitalists, we do our notes and essentially everything in the computer. So as hospitalists as a group, we really, as of right now, don't do much if anything, in the paper world, we'll say. So inpatient consultations, we work very closely with the other specialists, whether it's gastroenterology, the kidney specialist, the heart specialist, the lung specialist, close contact with them, coordinating care for the patient. And we tend to have very close relationships with the other providers. Perform various procedures if needed during the day. And then another big function is discharge care, arranging and coordinating appropriate timely discharge. As you saw, this becomes a difficult management with also trying to get the patient out in a timely manner, but then hopefully the patient's not readmitted. As I was mentioning, going back up, with the coordinated care, it really involves, it's like a team effort to get everybody involved. Certain patients are very challenging in this process, so it does take a lot of effort to, we'll say, discharge them in an appropriately timely fashion. Yes.
Question, let's say a patient comes into the ER, goes to medical imaging, has a procedure done, the radiologist writes orders, patient is admitted. What happens to those orders? Does the hospitalist take those orders into consideration, and then the hospitalist admission orders override those, or are there actually two sets of orders then?
Usually I think that, well, medical imaging, if there's an order already in there, if there is an outpatient, is that what you're referring to?
Let's say the patient's going to be admitted.
Okay.
The radiologist says in 6 hours
Do this.
Patient. Does the hospitalist orders override those on admission?
Yes, and did everybody hear the question? Sure, okay. The question was if the radiologist puts in some orders and the patient's admitted, I guess which orders, and the hospitalist wants to put in some orders, what takes precedent. Once they're admitted, we'll just go with the hospitalist admitting orders. And sometimes what happens, a different scenario happens, is if the radiologist or a primary care provider has an order already in for a procedure and the patient ends up being admitted. So to say they have an MRI order for a certain date and then the patient's admitted, then again, the order of the hospitalist supersedes it. The radiology department is outstanding. Duplicate things don't happen. It wouldn't be like you'd have 2 MRIs of the brain in the same day. If something were to happen along those lines, usually the radiology technician, the department, or the radiologist will contact us and we'll get that squared away. So it's rarely, I've never really heard of that, 2 of the same study being ordered in the same day. But the hospitalist orders will take precedent there. And now a little bit on the Agnesian HealthCare Hospice. The hospitalist program was started in 2006. The hospitalists admit a wide variety of patients. Our patients come from satellite clinics, various satellite clinics, other healthcare organizations, from correctional and jail patients we take care of, transfers from surrounding hospitals, nursing home patients, any of the patients in nursing facilities. If they don't have a primary care provider who admits, we admit for them, and then unassigned patients. And unassigned patients are patients who don't have a primary care provider or from maybe have a primary care provider and from outside the area. At St. Agnes Hospital here, there's, I believe, about 6 family physician doctors that admit. Other than that, we handle all the patients that are I'll say medical patients. Surgical patients still may be admitted by the surgical teams, but we handle all the primary medical admissions. And on the weekend, we handle coverage for them also. So essentially Friday through Monday morning, we handle their coverage for the family medicine, those few family medicine providers that admit at this time. Average, if you're wondering, about 10 to 15 patients. That sometimes goes higher than that, depending on how busy it is. Maybe up to 20 plus, and sometimes a little bit lower than that. Today? Per day. I thought you said today. I don't know yet, I'm here. At St. Agnes Hospital, we have 7 full-time hospitalists. We do utilize a few other part-time as needed for vacation coverage and such. But we have 7 full-time hospitalists. We have 4 nurse practitioners, and that outstanding, really outstanding nurse practitioners. Waupun and Ripon have 2 hospitalists. And for St. Agnes Hospital, we do 24 hours, 7 days a week coverage. Someone's here on site. I think that goes to the value of accessibility. I'll use the example of overnight. If a patient needs to be monitored closely, condition changes, there's hospitalists here on site to be able to react rapidly. Smaller hospitals, you don't necessarily need that. Given the acuity or the level of sickness of the patients and the volume, you don't necessarily something you really need. But at larger institutions, you probably need somebody on site all the time. And then we can take a look at the hospitalist team. This is Milani, one of our nurse practitioners, Dr. Chamsidon, who helps provide coverage as needed frequently. Dr. DeLima and Dr. Taylor, a couple of our full-time hospitalists. Dr. Spiritu, another full-time hospitalist with us. Rachel Klowski, nurse practitioner. Dr. Lee, myself, and Dr. Galina, Dr. Galina Petrinska and Dr. Amy Reef, both full-time hospitalists, and Anne-Marie Swanson and Billy Surgeon, nurse practitioners. And then Dr. Eisenberg helps provide coverage mainly at Ripon. Dr. Sala, director at Ripon Waupun, helps provide coverage at those institutions. And with that, thank you very much. The questions, comments?
So how does your doctor, I have a primary care physician in an outpatient setting, Dr. Milani, and I'm hospitalized. All kinds of things happen to me in the hospital, and you care for me personally. And then I'm discharged. How does my primary care doctor know then to follow up with me and do all the things that they need to do to keep me out of the hospital?
Right. Our system here is outstanding if they're within the system. If it's an Agnesian HealthCare provider and an outpatient, they can essentially they get a notice that you're admitted, okay, and then they can follow along daily. They can see the labs that we do. They can see the studies we do, and then our notes, specifically our hospice notes, are on the computer, so they can follow along. And when we first started that, we got quite a few compliments. That's very nice. We can read what you're exactly doing to the patient on a daily basis. When they're discharged, the discharge summary goes, we'll say, right into their inbox. They're aware you're discharged, and our system is so good here that they essentially, we do in our discharge summary, our recommendations, they see it, and then within the appropriate time, they follow up. If we say follow up within a week, they follow up the patient within a week. So it's a very good system. If they're, and if we need to, we'll give a call to them and discuss it in depth. There are certain conditions we will. But essentially, that's how we function. If the patient is outside the system, it's a little bit trickier. Again, our medical records is very good in getting the records to the primary provider, so we send it. So usually they get the information fairly quickly. They get the admitting note or the H&P rapidly from our medical records. And then we'll give them a call and contact them. And also once they're discharged, they'll get the discharge summary. And again, we can call and discuss the patient and what needs to be done. So it's a pretty nice system. It seems to work well. And also, if you're outside the system, we'll make recommendations, and unit secretary and such makes a follow-up appointment, so the primary care provider also knows that their patient was admitted. So I think it's one of the, we'll say, difficulties of hospitalists is that because you don't practice outpatient, making sure the primary care provider gets the information. As I said, certain places it's very difficult. That is a challenge. If you're, let's say, Milwaukee and it's really widespread, a lot of physicians, that could be a little bit of a challenge. That can be, from a hospital standpoint, that can be time consuming. Our system within, especially Agnesian, is so nice from that standpoint that it helps facilitate the process of keeping the primary care informed. And like I said, they can follow on a daily basis if need be what's going on to you. And some of them do pretty closely. Yes, we'll start from.
As a consumer of healthcare, how does the billing happen? I can remember in the past when my daughter was hospitalized, we get all these bills from doctors we didn't even recognize their names. So how does that?
They were probably all hospitalists. Sorry about that. Steve, could you refund so much? No. How does the billing? The hospital, what's happening more and more, healthcare organizations are essentially, physicians are working for healthcare organizations, and the healthcare organization, Agnesian, bills for us. So, and this is a great point though, is that, and I probably should have mentioned it a couple of slides ago under the patients we take care of. We'll treat the patient regardless of insurance or accessibility. We treat everybody essentially the same. Very rarely, someone may make a comment that maybe you're not doing something because of insurance. And as hospitalists, that's one of the advantages of being a hospitalist. And a lot of us went into it initially was that you really don't have necessarily that immense amount of paperwork if you're, let's say, private practice. So everybody's treated equally, regardless of you have insurance, you don't have insurance, or along those lines. You'll be treated equally, and then the billing that's all complicated. And other.
Why don't you answer the question?
I didn't hear the question.
So with hospital assistant billing, any different? So do you still get a bill for the hospitalist?
The professional fees,
Yes.
yes.
So to answer your question, you still get a bill for the hospitalist, a separate professional bill for the work that Dr. Milani does and cares, while he cares for you while you're in the hospital. That's billed separately from the St. Agnes bill. Is it right? No. We have a long ways to go in this country as it relates to medical billing, so stay tuned.
So if you're in the hospital alone, you would have a hospitalist and get individual bills for each one? No, it would all be the same bill.
The date of service is what will drive your bill. So you'll get a bill, and on that it'll have Dr. Milani, X amount of care delivered, hundreds of dollars, and then Dr. Spiritu, da-da-da-da. So they'll be all on one day. So it's your date, it's the event that drives the bill.
In a comment, this is universal. This is not here. This is essentially nationwide. I don't think it's pretty.
One thing that we're doing to help with that, who is this doctor? I've never heard this doctor's name. From a marketing standpoint, we're putting in information in inpatient rooms, so that they can be more familiar with our hospitalist program. And who was that guy that was just here? And the family asked. So we are doing things from a marketing, customer experience standpoint to help mitigate that.
In a comment along those lines, it's not necessarily just the hospitals. Other professional fees, such as we'll say anesthesiologists, you might not necessarily remember the interaction, but they did perform a valuable service for that, and that's just
Dr. Milani, I could add to it. If you when Ripon Hospital opens, we're using technology from Cerner that when the provider walks through the door, they have a little RFD on the inside of their badge, and that will trigger the person's picture to come up on your flat screen TV, and it'll say, oh, Dr. Milani is now entering your room. And so that technology will be present in Ripon. So if you ever want to try that out, get admitted to Ripon.
That'll work for all associates that provide
Oh, is it?
services in Ripon. So
Outstanding.
be it a dietary associate or a
Right.
environmental services and
So we'll see how it works in Ripon, Nance,
you bet.
and then maybe move it to other parts of our ministry as well.
Yes, Mr. Mugen.
Dr. Milani, we hear sometimes negative things about computerized physician order entry. From the hospital standpoint, what do you think of that?
Hospice, I think, universally really like it. I think it makes just providing care better. I know certain providers, maybe outpatient, it's a little bit different environment, but from a hospice standpoint, I personally, I don't want to talk for everybody. I think universally we really like the system. To give you an example, we could be across the hospital. We may get called by a nursing staff for an abnormal lab. We want to put another lab in. The old system, you'd have to either go across the hospital and put it in the chart, write it in the chart, or tell the nurse who maybe have to read it back, then the nursing staff has to go find the chart, write in the chart, goes to the unit secretary puts it in. This system, they call us, okay, thanks, we want to put it in, just go to the lab and put it in, it goes right to lab. Go to the computer, put it in, it goes right to lab. So universally, I think it's hands down, not even a question actually, from a hospital. Yes?
Dr. Milani, I have a question regarding patients that are discharged from our hospital that don't have a primary care physician following them. And so if they're admitted to an ancillary service like home care or home infusion, what happens?
That's a challenge. That's a challenge nationwide. I was just reading an article about that. What we do is they get one subsequent follow-up care. Beyond that, it's up to making arrangements. But we do with the primary care physicians. We essentially, I don't want to say have an agreement, but they do provide care subsequent to the hospital care, hospitalization. And that's one of the challenges nationwide and for hospitalists as a whole is that it's a source of, we'll say, liability. If you don't have a patient follow-up or you have, let's say you order a lab or study, who's going to follow that up? What we do is if the patient doesn't have a provider or does, if we order any tests, any studies, we'll follow them up and we'll contact the patient and go from there. But we have a system that hopefully gets the patient in to see a primary care provider on an outpatient basis. Yes, Jane?
I'm just wondering, hospitalist is fairly new and maybe for older people, they don't understand it. When they're admitted to the hospital, is it confusing to them as far as like, where's my primary care doctor? Who communicates to them what's going to be happening?
The nursing staff will communicate initially, I would say, or it depends on when we're seeing, but nursing staff communicates, and we have brochures also, so I guess a good segue to that, I don't know if it's done. But we have brochures with all the hospitalist names on it that are in the rooms right now. The hospitalist also communicates with them. And I'll say a few years ago, I think that was a bigger issue than it is now. I think it just seemed I know this is the healthcare associates here, but in general, I don't see that as much as a problem. I think people are kind of understanding the hospitals takes care of them. If they have questions, we readily answer them. But I think as of now, it's become less of an issue. And if they ask, we'll let them know that the provider doesn't admit to the hospital longer. They'll follow you up as outpatient, and we'll take care of you while you're here. So, yes.
How do you communicate, with your patient who has a wrong physician? And they get discharged. Do you automatically send a discharge summary to those outside physicians? Because it seems like, from my standpoint, it seems like all the doctors and the primary care patients in the hospital, they get notified when we're inpatient, but I feel they should be notified when they're discharged, so that they have the opportunity to discharge summary.
Sure.
I know the full outcome of that hospitalization, and I think that's a lack of communication, and, it really does, we want to do well with the patient, and we haven't communicated with primary care. I know you say CERN, but if they know when they're discharged, they can make a discharge summary, with an idea of what's going on. A lot of doctors really want when the patient's discharged, and also they get treated by, they follow up, and, I find that's detrimental care, because they aren't well communicated with physicians.
Sure. The question was, patients are discharged, is communication made about the discharge, and are they getting the discharge summary, the discharge information? I guess the answer to that is they should be getting it. Certain environments they might not. When we do a discharge summary, essentially there's two ways that it'll go right to them. We just say on our discharge summary when we're dictating it, send it to this provider, and it goes right into their inbox. The other way they get the discharge summary is that when we go to sign it off, we can send it to their inbox. Also, I'll say the primary care providers know if they're in the Agnesian system. If you're out of system, it becomes a little bit trickier. But if you're in the system, you actually get a note that a patient's admitted. So those are multiple ways. And then also at the time of discharge, we contact, not all of them, but it depends on the patient's condition and follow-up. We'll contact the primary care provider. And lastly, the appointment being made with the primary care provider. So it's not a foolproof system. There could be times that it doesn't happen. But I think there's enough, we'll say, kind of catches to hopefully one way or another they'll convey the information. To give you an idea, discharge summaries are essentially, you have to do them for billing. So there's no patients that leave the hospital without a discharge, unless it's a very, very short stay. So all patients are going to get a discharge summary. There's no way around it. If you don't do it, you actually end up getting, this is not here, it's universally, you'll be suspended privileges. So they should get a discharge summary. Again, sometimes it may slip through the cracks, but we try to do the best we can.
Just add to that a little bit. Agnesian HealthCare participates in a statewide health information exchange called Wisconsin Statewide Health Information Network. And we will be submitting those discharge summaries or a document called CCD, care continuation documentation, to that repository. And any provider in the state has the ability to access that exchange and grab that information off. Agnesian HealthCare is a leader in that space today. We're already providing lab results and microbiology results and all of our ADTs. So as soon as we are up on the next release, and which will be very shortly, of CERN, we are able to push that
a couple of notes on that is the notification if they're outside the system, like I was mentioning, becomes trickier. We'll get patients from outside the state. So that's where we weren't contacting the primary provider. As I said, the medical records are very good in tracking down, actually I had class of them amazing tracking down primary care providers and getting the information to them. So that becomes a little bit trickier, but it's, on both ends, it's kind of responsibility of the primary care provider, but as a hospitalist, you really have to make an effort also if they're outside the system especially. It kind of a challenge as the wide variety of patients we admit, some don't even have primary care providers, it's a large percentage. So then that becomes, added challenge. Well, okay, you have a patient who doesn't even have anybody to follow up with. So there's nobody to send anything to, and then at discharge, you gotta coordinate that. And that's what I was talking about, the really coordinated care of, that becomes a challenge. And then there's a percentage of patients who just don't follow up. That's, yes.
In general, maybe it's not as applicable here, but
Great question. The hospitalists do, not us. Here it's 18 and above. We make some exceptions depending, but generally it's 18 and above. There are pediatric hospitalists. They're at children's hospitals, and I guess Fox Valley, Milwaukee, Madison, but there are pediatric hospitals, mainly at children's hospitals. Mm-hmm. Yeah, and we don't have, and the patient population, the pediatrics here handles them. And then there's that kind of gray zone that, they're maybe less than 18 years age, but they're adult, we'll say, in size and such, so we'll help out with those cases. Yes, Mr. Moore.
Dr. Milani, you and I have talked frequently when we're trying to recruit someone into the program. You talk about the services we have here at Agnesian HealthCare. How would you rate our services based on your experiences at other places when you worked in the past, and as you tell new people coming in, whether it's care management, imaging, the navigators, lab services, how would you rate our services?
I think really, and I'm not just saying this because I work here, but overall, not because our boss, Steve Little's here. No. No. Overall, I think some of our services are just outstanding. The care management is it's almost a planted question. No, care management is outstanding.
Did you guys coordinate?
No, in general, you ask, not myself, any physician who's come in from an outside organization, and especially, let's say, a major city, as you saw, my background, some of the largest areas, Los Angeles, Milwaukee, the ancillary services across the board is outstanding. Not all of them, but on the whole, some of the services are outstanding. Almost, my view is we take it for granted in the community. It's that good. And we're held to such a high standard, and that should be like that, but I really think overall the healthcare organization is just outstanding compared to other places.
Do we have one more question for Dr. Milani? Sister Mary?
Yes.
What percentage of our people, when they leave, don't have a primary care? I mean, just a general.
I don't know the exact percentage. I'd say when they leave or when they come in. I think
When they leave. When you don't have any place to send it.
Well, we'll always have a place to send them. They'll always get a place to go after. We'll plug them into the system or somewhere. We'll coordinate something. So they'll always have a place to go. They follow up, I don't know, but necessarily. I would say maybe about 20% of our patients don't have anybody coming in. But we'll always coordinate something for them for follow-up.
Okay, thank you.
So let me understand that, Dr. Milani. So if Steve Little comes in and he's not a primary care physician, and so you discharge, you'll actually coordinate or help coordinate Steve Little to get connected with the primary care physician within our network.
Yes, absolutely. No, thank you. Yeah, absolutely.
On that note, let's give Dr. Milani a round of applause.